Good evening, everybody. I am Dr. Mayur Veera, and today I am going to speak about imaging in ovarian neoplasms with an overview of MR ORADS. First, the imaging techniques in ovarian neoplasms. Sonography remains the first line imaging modality of choice for assessing adnexal masses. MRI is generally considered as a second line problem solving tool in complex adnexal masses. Role of imaging is to characterize the lesion between benign and malignant, determine the extent of disease, predict the resectability, evaluate treatment response, and localize the recurrence. Biopsy is generally not suggested because peritoneal seeding can upstage the tumor. MRI protocol to be followed for assessing adnexal masses. Sagittal and axial T2 weighted images without fat saturation, which are of 3 to 4 mm in slice thickness or less. Axial in-phase and out-phase T1 weighted images. Diffusion weighted images. Dynamic contrast imaging is always preferred over non-dynamic contrast scans, and a delayed non-contrast 3D T1 weighted fat images with fat saturation should be performed. Coming to ORADS, Ovarian Adnexal Reporting and Data System. It was developed and published in 2018 by an international multidisciplinary committee. It was sponsored by the American College of Radiology. Originally, it was designed for sonographic evaluation, but in 2020, its MR evaluation was also incorporated. It is a system to ensure a uniform and unambiguous MRI evaluation of adnexal lesions and assigning each lesion a risk category score, which will inform the physician about the appropriate management to be followed. Primary goal is risk stratification and to improve the communication between radiologists and physicians. Another advantage of MRI ORADS over ultrasound ORADS is to reclassify the lesions which have been labeled as suspicious or indeterminate on USG. It is also useful and research and education purpose because it has a uniform way of reporting. The basic concepts to be followed while using the MR risk score. Only average risk patients are taken into consideration. That means patients with high risk factors, for example, personal or family history of breast or ovarian cancer patients are not taken into account. There should be no acute symptoms present at the time of diagnosis. We have to categorize the patient into pre and post-menopausal. In case there are multiple or bilateral lesions, then each lesion should be given a separate score and management will be decided by the lesion with highest score. It does not apply to lesions which are of non-ovarian or non-adnexal in origin, and always dynamic contrast imaging is preferred over non-dynamic contrast scans. The ACR committee has given us a basic lexicon, that is standardized terminologies and definitions for assessing and reporting the adnexal lesions, where the characteristics of the ovarian lesion have been given standard definitions. For example, its signal intensity, the enhancement pattern, the fluid component of the lesion, the solid component of the lesion. Everything has been defined well in this lexicon. Signal intensity of the lesion can be either homogeneous or heterogeneous. Homogeneous, which has uniform signal, and heterogeneous, where there is mixed signal intensities. On T2 weighted images, we compare the signal of ovarian tissue with that of iloPSOAS and CSF, and accordingly we grade the signal as hypointense, intermediate, or hyperintense. On T1 weighted images, again, the signal of the lesion is compared in relation to the iloPSOAS or fat. Something that is as bright as fat on T1 weighted images is hyperintense on T1. A lesion is a finding which is associated with ovary and adnexa that is not normal or physiological. The types of lesion as per the lexicon, they are divided into cystic lesion, that is fluid containing lesions which can be unilocular or multilocular. Cyst with solid component or solid lesions which contain at least 80% enhancing solid tissue. The fluid descriptors of the lesion. Fluid within the cyst can be either simple or non-simple as per the lexicon. Simple fluid is one that follows the same signal intensity as CSF. It will appear bright on T2 weighted images and dark on T1 weighted images. Non-simple fluid will have variable signal intensity on T1 and T2 weighted images. Generally, they are bright on T1 weighted images, and if it is a non-lipid containing fluid, it will not show any signal suppression on fat sat images. Non-simple fluid can be endometriotic, hemorrhagic, proteinaceous, mucinous, or lipid containing. Solid component of the lesion. Any part of adnexal lesion which is not fluid is all included in this solid component. Solid components are divided into the solid tissue and other solid components. Solid tissue is defined as one that enhances after the contrast administration. And these have been subdivided into papillary projections as seen in this first image, which has a branching appearance more than 3 mm in size, and it will form an acute angle with the cyst wall. Mural nodules, it will have upper convex margins, again more than 3 mm in size, and they will form an obtuse angle with the cyst wall. Irregular septae within the cyst or larger solid portions are all included within solid tissue, and these are the the solid tissues are the ones that upgrade the ORADS score to 4 or 5. Other solid components include smooth septae, blood clots, debris which do not enhance on contrast images, fibrin strands, and fat. These are the ones which are not going to upgrade your ORADS score. Time intensity curves and dynamic contrast imaging. Whenever we are performing the dynamic contrast scan, we have to start the injection of contrast medium after 30 seconds of the scanning and without interruption of the scan. While post-processing the images, we have to scroll through the entire lesion and look for the earliest and the most enhancing area within the ovarian solid tissue, where we have to place an ROI. A second ROI or region of interest is placed over the myometrium to compare the enhancement pattern. We should take care to avoid placing the ROI over any vessel. There are variation in myometrial enhancement throughout the menstrual cycle, and this variation has been found to be maximum in the junctional zone as per the studies. Hence, this junctional zone and inner myometrium is usually avoided, and we place the ROI over the external myometrium to avoid the variability. 3 types of time signal intensity curves have been defined as per the lexicon. The low risk time intensity curve is where the rise in signal intensity of the ovarian soft tissue is lesser and slower as compared to the myometrial enhancement curve. This curve will not have a shoulder and a plateau as seen in this myometrial curve. In intermediate risk time and signal intensity curve, again, the rise in signal intensity of the lesion will be slower and lesser as compared to myometrium, but this curve will have a shoulder and a plateau similar to that of myometrial curve. In high-risk time signal intensity curves, there will be an initial brisk rise in signal intensity of the lesion following contrast administration, and the slope of this curve will be higher than the myometrium. Coming to different ORADS categories, ORAD 0 is incomplete evaluation, where the study is technically inadequate, where not all the required imaging sequences have been performed, or there are a large amount of artifacts seen, which makes the study unreportable. ORADS 1 includes normal ovaries or physiological findings. The appearance of normal ovary on MRI, where there is no adnexal lesion, included in ORADS 1. A follicle is defined as cyst with less than or equal to 3 cm in diameter in a premenopausal woman. It is a physiological finding and hence included in ORADS 1. Hemorrhagic cysts which are less than or equal to 3 cm in premenopausal women are also included in ORADS 1. Corpus luteal cysts are also physiological findings in premenopausal women which are of less than or equal to 3 centimeters. They are seen as slightly thick-walled small cystic lesions which show intense wall enhancement on contrast scans, and there will be associated minimal fluid in pouch of Douglas. ORADS 2 includes almost certainly benign lesions and These include unilocular cysts with any type of fluid content, that is simple or non-simple fluid, but there should be no wall enhancement. There should be no enhancing solid tissue. Unilocular cyst with simple or endometriotic fluid content with smooth enhancing walls but no enhancing solid tissue are also included in ORADS 2. The middle image here is an example of an endometriotic cyst which is showing the characteristic T2 shading effect. The uppermost portion appears bright, intermediate portion is gray, and the lowermost portion is dark. This is blood of different age groups seen in endometriotic cysts. These cysts usually show smooth wall enhancement. No enhancing solid tissue is seen in this case, and hence it is an ORADS 2 finding. Lesions with lipid content. They appear bright on T2 and T1 weighted images. They show suppression of signals on FATSAT images. We will see two different scenarios in lesions with lipid content. In the first scenario, where there is no enhancing solid tissue seen, this will be included in ORADS 2, and these are usually the mature cystic teratomas. But in case if we find an enhancing solid tissue along the cyst wall in lesions with lipid content, the score would be upgraded to ORADS 4. These are examples of immature cystic teratomas or teratomas having a focus of squamous cell carcinoma. Entirely solid lesions, which are uniformly dark on T2 weighted images, showing no restricted diffusion, are examples of benign fibroma and thicoma. They are included in ORADS 2. Dilated fallopian tube or hydrosalpinx and para-ovarian cysts with smooth wall enhancement, no enhancing solid tissue, are also included in ORADS 2. ORADS 3 are low-risk category lesions, where positive predictive value for malignancy is less than 5%. These include unilocular cyst with non-simple fluid. As we can see, the fluid here is bright on T1 weighted images. It is not showing any signal suppression on FATSAT images. That means it is a non-lipid containing fluid. Smooth enhancement of walls is present, but no enhancing solid tissue is seen. ORADS 3 finding. Multilocular cysts with any type of fluid content showing smooth enhancement of septae and its walls, but no enhancing solid tissue is seen, are also included in ORADS 3. So, up to ORADS 3, there should be no enhancing solid tissue seen. ORADS 4 and ORADS 5 category lesions are lesions with solid tissue. The main difference is their enhancement curve. An example here of ORADS 4, it is a cystic lesion with a eccentric solid tissue seen. This solid tissue is showing enhancement on contrast images. Visibly also, this enhancement is less as compared to myometrium, and this is further confirmed on this time signal intensity curve, where we are getting this intermediate risk time signal intensity curve, which we had seen in the lexicon. This is an example of ORADS 4, which are intermediate risk category lesions having positive predictive value for malignancy ranging from 5 to 90%. ORADS 5 are high-risk category lesions with positive predictive value for malignancy more than 90%. They are also lesions with solid tissue, but they would show a high-risk time intensity curve on dynamic contrast imaging. An example of ORADS 5, this is a moderate-sized ovarian lesion where there is a significant amount of solid tissue showing avid enhancement on contrast study, showing a high-risk time intensity curve. We can see the blue slope here of the ovarian lesion, which is the slope is higher than the myometrial curve. Also, ovarian or adnexal lesions which show peritoneal, mesenteric, or omental nodularity with or without ascites are also included in ORADS 5 category. If dynamic contrast imaging is not performed, Can we still use ORAD scoring? Yes, we can use it, but we can only comment if the enhancement is less than myometrium, that is ORADS 4, or enhancement is greater than the myometrium, ORADS 5. We cannot really differentiate between ORADS 3 and ORADS 4 without a dynamic contrast scan. The ORADS calculator, it is a free tool available over the ACR website in the ORADS section, where we have to answer a few questions about our ovarian case, and it would automatically generate an ORADS score for us. It is a free tool available on the ACR website. Coming to classification of ovarian neoplasms, they are broadly subdivided into four main categories: epithelial cell tumors, germ cell tumors, sex cord stromal tumors, and metastasis or miscellaneous lesions. Of these, the most common is the epithelial cell neoplasms, and these include serous, mucinous, endometrioid, clear cell, Brenner's, seromucinous, and undifferentiated varieties. Germ cell tumors include teratomas, dysgerminomas, yolk sac tumors, embryonal cell carcinomas, choriocarcinomas. Sex cord stromal tumors include granulosa cell tumors, fibromas, trichomas, Sertoli Leydig cell tumor, and steroid cell tumor, and the last is metastasis. We are going to see examples from each of these few categories. Starting with the epithelial cell neoplasms, the first is benign serous neoplasm or serous cystadenoma. This is the most common ovarian neoplasm, and it is seen as unilocular cyst with absence of septae or solid components. Persistence on follow-up imaging is a key distinguishing factor from a functional ovarian cyst if the patient is still ovulating. Borderline serous cystadenomas and low-grade serous cystadenocarcinomas. They have got overlapping imaging features. They are seen as cystic lesions with variable amount of solid tissue, which would enhance on contrast imaging. Below is an example of a low-grade serous cystadenocarcinoma where there are few enhancing mural nodules seen along the cyst walls. High-grade serous cystadenocarcinomas are the most common malignant ovarian tumors. They manifest in the 5th and 6th decade of life. They are seen as cystic masses with variable amount of solid tissue, which intensely enhances on contrast imaging. In 50 to 60% cases, they are bilateral, and in a lot of cases, they present at an advanced stage, including having peritoneal metastasis. This is an example of high-grade serous cystadenocarcinoma. Mucinous neoplasms, the benign, borderline, and malignant ones. They affect a younger age group as compared to serous neoplasms. Malignant variety has a poorer prognosis as compared to rest of ovarian neoplasms. They are seen as cystic unilateral masses which have multiple locules, and each locule will have a varying signal intensity on MRI. Image is on the right, an example of a cystic lesion which is multilocular on T2 and T1 weighted images. Each locule, as we can see, has a different signal intensity, and this differences in signal intensity is due to the different viscosities of mucin within these locules. This appearance has been termed as stained glass appearance because of its similar appearance to a radio-opaque glass. The brightness on T1 weighted images is not showing any signal suppression on FATSAT images. Subtracted T1 weighted images, they show smooth enhancement of septae and the walls. This is a benign mucinous cystadenoma. Mucinous cystadenocarcinomas, they are also seen as unilateral cystic lesions which has a multilocular appearance, and the locules will have different signal intensities. On contrast imaging, the septae will show irregular enhancement and there will be variable amount of solid tissue seen. Remember, primary mucinous neoplasms are usually unilateral in majority of cases. In case if we find bilateral ovarian lesions which are having mucinous characteristics, we should always rule out metastasis to ovaries from primary GI origin. In germ cell tumors, we have already seen the examples of mature and immature cystic teratomas in the ORADS section. We will directly now jump to dysgerminomas. They are seen in younger age group. They are well encapsulated multilobulated lesions, predominantly has solid tissue. These lesions will have these thin fibrovascular septae seen as thin black lines. And this is a typical or characteristic imaging finding of dysgerminomas seen in younger age group. These lesions show intense enhancement on contrast study and restricted diffusion. Sex-cord stromal tumors of ovary, they affect all age groups. They are hormonally active tumors having estrogenic effects or virilization. Hence, they are diagnosed earlier than the epithelial neoplasms. They are primarily treated surgically and have good prognosis. The most common sex-cord stromal tumor is a fibroma, and most common malignant sex-cord stromal tumor is a granulosa cell tumor. Fibromas were also discussed in the ORADS section. These are solid lesions which appear uniformly dark on T2 and T1 weighted images and they have variable amount of calcification seen on CT. They are the most common sex-cord stromal tumors and usually they do not have any estrogenic activity. Granulosa cell tumors have got malignant potential. They have varied appearances on imaging. They can present as entirely solid lesions. They can present as completely cystic lesions, or they can be seen as multilocular cystic lesion as seen in this example. This is a cystic lesion having multiple locules and locules are filled with fluid. Some of the locules are having hemorrhagic components here and it is showing non-homogeneous contrast enhancement, an example of granulosa cell tumor. Metastasis to ovary. It is very difficult to differentiate metastatic lesions to ovaries from primary ovarian neoplasms. However, there are a few features or findings which can help us diagnose this. For example, smaller size of the lesions as compared to primary ovarian neoplasms. More often, they are bilateral. They have uniform signal intensity in the locules. Enhancement of solid components would be higher or of moderate degree as compared to primary ovarian neoplasms. And elevation of CA125 levels will be relatively less as compared to primary ovarian neoplasms. Studies have shown that a combination of these features, for example, patient's age, slightly younger age group of premenopausal status, smaller size of lesions, and bilaterality of the lesions, these three features together, they tend to have a higher sensitivity and specificity in diagnosing metastatic ovarian lesions than the individual features alone. Most commonly, metastasis to ovary occurs from stomach or colorectal carcinomas, and these are known as Krukenberg's tumors. The black scrunchy sign is a sign which is seen in metastasis to ovaries from primary gastric tumors. It is defined as a peripheral thick hypointense rim which and having a central hyperintense area on T2 weighted images. Example of black scrunchy sign. Peripheral hypointense rim is seen with central hyperintense areas. This peripheral hypointense rim is showing restricted diffusion. There is also a one other peritoneal deposit seen. Another example of black scrunchy sign in this case of primary gastric tumor having bilateral ovarian metastasis. Peripheral thick T2 hypointensity is seen with central hyperintense areas. Lymph nodal involvement in ovarian tumors. Size criteria, more than 10 mm in ovoid lymph nodes and more than 8 mm in rounded lymph nodes is significant. Morphology-wise, loss of fatty hilum, necrosis, and calcification are signs of metastatic nodes along with extracapsular spread, better demonstrated on MRI. Normal appearance of lymph node, which is ovoid and has a fatty hilum. Appearance of a metastatic node showing loss of fatty hilum and a rounded shape. Lymphatic spread from ovaries occurs through two main pathways, following the broad ligament into iliac and obturator group of lymph nodes, and another following the infundibulopelvic ligament into para-aortic lymph nodes. Third uncommon route is through bilateral round ligaments into external iliac and deep inguinal lymph nodes. Remember, metastasis to deep inguinal lymph nodes is FIGO stage 4 disease. Both pelvic and para-aortic lymph nodes could be seen as primary metastatic sentinel lymph nodes in ovarian tumors. Most commonly involved lymph nodes are para-aortic group of lymph nodes, external iliac group of lymph nodes, and third being the obturator group of lymph nodes. The sites where we can find para-aortic, external iliac, obturator, and internal iliac lymphadenopathy. Both unilateral and bilateral ovarian neoplasms can involve bilateral pelvic lymph nodes. Another important group of lymph nodes are the cardiophrenic group of lymph nodes. These are seen in advanced ovarian tumors and diseases with peritoneal dissemination in up to 30% cases. A short axis cutoff for 5 mm is significant. Anything above 5 mm is significant and should be reported on the radiology reports because this would make the disease prone to suboptimal resection and would warrant neoadjuvant chemotherapy. Imaging in peritoneal metastasis. In order to understand the tumor spread within the peritoneum, it is necessary to know its anatomy and the function. Peritoneum has got two layers, parietal peritoneum lining the abdominal wall and visceral peritoneum lining the abdominal organs. Space between the two is the peritoneal cavity, normally contains 50 to 100 ml of physiological fluid. Peritoneal ligaments are double folds of peritoneum that support a structure within the peritoneal cavity. These peritoneal spaces and ligaments, they serve as pathways or gateways for the spread of disease within the peritoneum. Various peritoneal ligaments, suspensory ligaments of liver are falciform and triangular ligaments. Peritoneal ligaments of stomach include lesser omentum, greater omentum, gastrosplenic ligament, and splenorenal ligaments. Other peritoneal ligaments are small bowel mesentery, transverse mesocolon, and sigmoid mesocolon. The transverse mesocolon divides the peritoneal cavity into supramesocolic and inframesocolic spaces. In addition to that, we have paracolic and pelvic spaces. Supramesocolic space is subdivided into right and left by the falciform ligament. This dark band is the transverse mesocolon dividing the peritoneal cavity into supramesocolic and inframesocolic spaces. Supramesocolic space is subdivided into right and left by the falciform ligament. Right supramesocolic space is subdivided into right subdiaphragmatic, perihepatic, subhepatic spaces and the lesser sac. Left supramesocolic space subdivided into left subdiaphragmatic, left perihepatic space and the perisplenic space. Inframesocolic space is also divided by the mesentery into right and left. In addition to that, we have paracolic spaces on either side and the pelvic space, which are all communicating with each other. Role of radiologist in peritoneal carcinomatosis, is to diagnose it at an early stage. Exclude diseases which mimic peritoneal carcinomatosis, for example, tuberculosis, which can also present as omental thickening and ascites. In assessment of follow-up cases, to look for treatment response and to localize the recurrence. Peritoneal involvement can be either synchronous or metachronous. Synchronous presentation is one where we diagnose the ovarian tumor and peritoneal spread at the same time. Metachronous presentation is one where peritoneal spread is seen at a later stage after the primary curative surgery as a sign of recurrent disease. Routes of spread in peritoneal cavity. Serosal lining of ovary is continuous with that of peritoneum. Hence, there is direct exfoliation of cells from ovary into the peritoneal cavity, and further spread occurs by redistribution by gravity and following the path of normal peritoneal circulation. Redistribution by gravity causes the tumor deposits to settle in the dependent regions of abdomen and pelvis, that is in the paracolic gutters and in pelvis. Further spread occurs following the path of normal peritoneal circulation. Now, what is the path of normal peritoneal circulation? It is from caudal to cranial, that is from pelvis to subdiaphragmatic region. During expiration, as the diaphragm moves upwards, it will draw the fluid and the cells upwards towards itself due to the negative intra-abdominal pressure gradient, and therefore the flow of fluid and the cells is from caudal to cranial. Signs of peritoneal involvement. The first and the most common sign is ascites, which can be free or loculated, occurs either due to obstruction of lymphatics or excess production by peritoneal lining. Pelvic ascites is not very specific. Small volume fluid in pouch of Douglas is not a very specific sign of peritoneal involvement because this can also be seen in benign conditions, for example, ovarian torsions or pelvic inflammatory diseases. But in case we find abdominal ascites or slightly larger volume pelvic ascites that is fluid anterior to uterus, this is a more sensitive sign of peritoneal involvement. Greater omental involvement, invasion of the omental fat by soft tissue deposits. When the entire omentum is replaced by mass, it is known as omental kicking. This is an example of bilateral adnexal lesions, and moderate ascites in this case is a sign of peritoneal involvement. Greater omental involvement seen in this case, there is replacement of omental fat by multiple soft tissue deposits. Invasion of mesentery seen in this case as few nodules along the mesenteric folds, or there can be diffuse thickening of the mesenteric folds. In demonstrating the tumor implants over parietal peritoneum, most common sites being the subdiaphragmatic region, paracolic gutters, and pouch of Douglas. We can see small deposits here in bilateral paracolic gutters, and moderate sized deposits are seen in pouch of Douglas. Involvement of the visceral peritoneum over the liver and spleen, number, size, and site of deposits should be mentioned, and also look for if any secondary parenchymal invasion by surface deposits is seen. If it is present, it should be documented on the radiology reports as to which segment of liver is involved and what is the depth of invasion. Subperitoneal spread of disease is spread of disease along the peritoneal ligaments. As in this case, there are multiple deposits seen along gastrosplenic ligament, gastrohepatic ligament, along the falciform ligament, and involvement of lesser omentum has led to the disease spread to periportal space. Another example of peritoneal carcinomatosis where there are moderate sized deposits in right subdiaphragmatic region. Few deposits are seen in Morrison's pouch. A deposit is beautifully delineating the gastrosplenic ligament extending from spleen to stomach. Look for serosal deposits, which are also signs of visceral peritoneal involvement. It is seen as eccentric bowel wall thickening. In this case, it is involving an ileal loop and sigmoid colon, which is showing uptake on FDG PET images. These are better demonstrated if we use positive oral contrast medium. But we have to be careful because calcified peritoneal deposits can get masked if we use positive oral contrast medium. So I suggest that you should take a plain scan before starting the positive oral contrast medium in such cases. Multiple mucinous deposits in a case of mucinous ovarian neoplasm. It is causing extensive scalloping of liver surfaces, pseudomyxoma peritonei. Pelvic side wall invasion should also be looked for in cases of peritoneal metastasis. It is defined as mass reaching within the 3 mm of the iliac vessels or mass encasing more than 90% of iliac vessel circumference. We have different approaches and ways of reporting the peritoneal carcinomatosis. An easier way is to follow the path of normal peritoneal circulation. It is from caudal to cranial. On coronal images, start from the pelvis. Inspect the paracolic gutter. Look at the ascending colon, the hepatic capsule, right subdiaphragmatic region, the transverse colon, gastrohepatic and gastrosplenic ligaments, left subdiaphragmatic region, perisplenic region, the descending colon, paracolic gutters, again see the pelvis, and then finally look at the mesentery. Similar approach can be seen, then again followed on axial sections. Thoracic metastasis in advanced ovarian tumors. Diaphragmatic tumor implants, they cause pleuroperitoneal communication and allow transdiaphragmatic spread of disease into the thorax. Metastatic thoracic involvement is FIGO stage 4 disease. Whenever we see moderate to large amount of pleural effusions in ovarian tumors, along with supradiaphragmatic lymphadenopathy, there is a very high likelihood of metastatic involvement and it should be looked for carefully. Presence of pleural nodules or lung nodules, pleural thickening, pleural enhancement are signs of metastatic involvement. Also look for supradiaphragmatic, mediastinal, hilar, and supraclavicular lymphadenopathy. Multiple pleural deposits are seen in this case of ovarian carcinoma, and there is a malignant pleural effusion also detected. Peritoneal Cancer Index, developed by Sugar Baker at the Washington Cancer Institute. It is used preoperatively to determine the volume and extent of peritoneal disease. Final score decides if the patient is a candidate for cytoreductive surgery or not. Calculating the peritoneal cancer index, the abdomen and pelvis is divided into 9 regions numbered from 0 to 8 in a clockwise manner. The small intestine is divided into proximal jejunum, distal jejunum, proximal ileum, and distal ileum. Therefore, a total of 13 regions are to be inspected, and deposits in these regions are given a score according to their sizes. Total score is added together, and a maximum score of 39 can be achieved. Various organs which should be looked for in these 13 regions are tabulated here. You can take a screenshot of this, or it is available on the radiology assistant website. The FIGO staging of ovarian tumors. It looks complicated, but an easy way to remember this is stage 1 is limited to ovaries. Stage 2, the disease is limited to pelvis below the pelvic brim. Stage 3 is disease beyond the pelvic brim, or there is retroperitoneal lymphadenopathy. And stage 4 is distant metastasis. Now, ovarian cancer patients which are not candidates for primary surgery, these include involvement of small bowel mesenteric root, diffuse carcinomatosis of long segments of small bowel whose resection would lead to a short bowel syndrome, extensive involvement of stomach, duodenum, and proximal pancreas, involvement of celiac trunk or other major arteries, multiple lung metastasis, preferably biopsy proven, non-resectable lymph nodes, and brain metastasis. Coming to imaging referral guidelines. In the general population, for screening of ovarian tumors, no imaging is suggested because studies have shown that it does not lead to a significant reduction in mortality rates. Women with hereditary cancer syndromes, USG and CA125 levels should be started at the age of 30 to 35 years. In suspected ovarian lesions, USG is the first-line imaging modality of choice. In case the lesion is confirmed to be malignant on USG, we have to directly advise a staging CT chest, abdomen and pelvis along with oral and IV contrast medium. If the lesion is indeterminate on sonography, then only we go for MRI imaging. For assessing the treatment response, CA125 levels and CT are the standard tools. Rising CA125 levels after the treatment prompts for a recurrence, and we can either suggest a CT chest of the pelvis or a PET CT. In raised CA125 levels, if CT is inconclusive, we can take the help of FDG PET.